Thank you, Dr. Lewandowski, for the exceptional presentation.
I'd now like to announce a commencement of the panel discussion. Our panel will consist of Professor Dr. Nigat Amir, who is a professor and associate dean at the Institute of Rheumatic Diseases. Will Dr. Nigat please join us on stage? Professor Dr. Abid Farooqi, who is a retired professor of rheumatology at the Pakistan Institute of Medical Sciences in Islamabad. And Dr. Shabnam Batul, who is an assistant professor of rheumatology at Shalimar Medical and Dental College, Lahore. Will our panelists please join us on stage? I'd now like to invite Dr. Tahreem Tahir to present the first case for our panel discussion.
This is not the case. Bismillahirrahmanirrahim. Assalamu alaikum. I am Dr. Tahreem Tahir, Medical Officer, Rheumatology Department from Shalimar Institute of Health Sciences. Our case is about a young 20 years old unmarried female resident of Lahore who was diagnosed with systemic lupus erythematosus in the year 2011, and her initial symptoms included mostly skin manifestations with cutaneous ulcers and Raynaud's. The immunological profile done at that time included a positive ANA by IFA that had a homogeneous pattern. Her anti-double-stranded DNA and ENA by Contrix was also positive at that time. During the initial phase of her disease, during the initial years mostly, she had multiple flare-ups of her disease that included skin vasculitis flares, for which she had to undergo multiple amputations of her fingers and toes due to gangrene. The recent flare-up was in the year 2022 in May, when she presented to us with new onset of abdominal symptoms that included diffuse abdominal pain and vomiting. The EGD done at that time showed moderate to severe gastritis, but the abdominal ultrasound and CT angiogram were normal. We can see these images. These images show us the multiple amputations that she had to undergo, all in the duration of 1 year. We can see the multiple vasculatic ulcers in different stages of healing over both her upper and lower limbs, including both her hands, feet, along with both her legs. We had managed her with intravenous steroids and cyclophosphamide infusions, and then switched her to rituximab. She was previously given rituximab in 2017, after which she had lost to follow-up, and then presented again in 2022 with a flare-up of vasculitis, during which we again started her on rituximab. The challenges that we had to face during the management of her disease were the disease itself, that was difficult lupus with recurrent flares, and the fact that the disease was resistant to therapy. There was difficult pain control, and of course there was difficult intravenous access, for which we had to go for central line insertion for all her intravenous medications. And there were affordability issues, of course, and that led to poor compliance both to follow-up and treatment. And then there was psychological impact that the disease has had on the patient herself. Thank you.
Yeah, I think we she has presented the case, and
Okay.
I think the first question was this: how to control her flares? They were trying everything.
Yeah, that's
So, any other options for control
well,
of her flares?
as Dr. Hasni said, the two ways of viewing lupus is it one disease with several faces or several diseases with one face. And therefore, every patient with lupus is a different challenge, as was this one. We are struggling to find a cure. There isn't one yet. In fact, I might ask Dr. Hasni and Dr. Lewandowski, sorry, difficult for me to pronounce your surname, Laura. Just call you Laura, if I may. About your thoughts on the new CAR-T therapy that's been in the limelight recently. But given our own circumstances, the next options, if affordable, were either plasmapheresis or IVIG therapy, and beyond that, there was very little within our environment that we could offer her. High-dose steroids for what they're worth, mycophenolate for what it's worth. You throw the book at such patients and just hope that something works. And you stop wherever the finances make you stop. That is how I would tackle this case at present, and for future therapies, comments from our foreign visiting experts. And now up to Dr. Nigar.
Thank you, Abid. I just wanted to know, would you consider underlying vasculopathy contributing? Should we think about anticoagulation in this patient, work her up for APLs, etc.?
Oh, this was vasculitis. Those ulcers were vasculitic ulcers.
I'm
She
just saying,
definitely had vasculitis.
yes, I'm saying could vasculopathy have contributed? Could she
Yes,
also?
of course. Her main problem was vasculopathy now. This was the face of lupus that was being shown now. So all efforts to control the vasculopathy, the inflammation in the blood vessels, somehow to get her out of this quagmire. So yes, all efforts to control the vasculopathy.
Biggest challenge over here was the standard therapy, the methotrexate, the cytoxan, which are cheap, which are easily available. They had tried everything. IVIG and plasmapheresis is so expensive here that it's an excellent option, as you said, Abid, but very difficult to get this for patients who are so sick, very, very difficult. The other thing was this, that she did somehow responded to rituximab, which was much better than any other therapies which she got. But again, the question is that could we have done anything better apart from what we had already done, and which we obviously cannot afford the other two treatments. Yes, yes.
My question again is, would you consider, did you get antiphospholipid antibodies done as well in this patient? Two, would you consider, if they are positive, or would you consider a trial of anticoagulation on top of the vasculitic treatment? Yeah. Hasni?
At our institute, of course, we have that tertiary or maybe quaternary referral. So we get several of patients like that. And in fact, one of my patient comes to mind, very similar to this presentation. So to answer this specific question, she had the specific similar vasculitic type features, but the APLS was negative. But it's still, when you look at the biopsy, you see that there is a clogging of the blood vessels. So we did opt to start her on antiplatelet therapy. We started her just on aspirin, actually. But the other point is that in terms of treating these patients, we have found good success with making a combination therapy, because as you can see, the pathophysiology of lupus, multiple immune pathways are involved. So you have to attack them through multiple pathways. So just attacking the B cells by rituximab may not be enough. It may control one part of the immune system, but the other part is not. So we have treated close to about 40 patients with a combination therapy of cyclophosphamide and rituximab. So we give them rituximab on day 1, then day 2 we give them cyclophosphamide, and then 15 days later give them another dose of rituximab, and then continue with monthly cyclophosphamide for 6 months. And this has shown to be very helpful in terms of multi-targeted therapy. And I think for complicated patients like this, you have to target the immune system through different paths instead of just focusing on one treatment modality.
So how long would you continue that cycle of cyclophosphamide and rituximab in these patients?
So the induction is again the 6 months. So you give the rituximab 15 days apart, and then you give cyclophosphamide monthly for 6 months. And then you have, hopefully in that 6 month time period, you're able to at least control the disease with this heavy induction. And then you can go to maintenance. That could be either MMF, or you can also do quarterly cyclophosphamide and so forth. Or you can, every 6 months or so, look at if the B cells are repopulating. If you look at the CD19 cells, then you can maybe choose to give another dose of rituximab.
Thank you.
I really I'm just asking, like, if like belimumab and interferon type 1, which is recently FDA approved, and ifirolab, can they help in such conditions, though they are not available in this area, but like overall?
So they might, but
Yeah.
the thing is that if you look at the clinical trials where both the belimumab and interferon was approved, you can see that the effect size is not that huge though. And in clinical practice also, when you use belimumab, it is efficacious, but it's not hugely efficacious, especially for a complicated, severe patient like that. Probably that may not be as effective. You need to use big guns. So I think something to wipe out the B cells, which is rituximab, and something which is a pan-immune suppressant, especially looking at the neutrophil, because those are seems to be a major player. Probably cyclophosphamide would be better. Of course, we don't have any personal experience with that. I have experience with belimumab, but not as much with rheumatology, so time will tell. But I think probably my approach will be to use a combination therapy of rituximab and cyclophosphamide.
Thank you so much. I think we did give rituximab, and it's cost like almost $1,000. So Arthritis Care Foundation did support her Restova and all her therapies. So hopefully, we can do it's like a Euro lupus sort of a protocol, where you give first dose and second, and then cytoxin in combination. Thank you so much.
I just have a question that's been forwarded for Dr. Shabnam, who took care of this patient, regarding the outcome of her mesenteric vasculitis.
In her case, basically, like this time in May 22, when she presented, it was suggestive of mesenteric vasculitis, which responded well to IV steroids and rituximab. So that was acting dual therapy for her complications of cutaneous vasculitis as well as of mesenteric vasculitis.
Thank you everyone. Now we have a second case,
Excuse
which
me.
is very
Assalamu
interesting.
alaikum. Dr. Nigar, can I add something to Dr. Hasni's point of view? Actually, we did have such patients, and we did the same regime, but unfortunately, the patient succumbed to the infection and they passed away. So another major thing we face here is the infections. So the patient was sick and did not respond to rituximab and cyclophosphamide and all that, and later on we opted for combination. And so that's why we are really, thinking twice or thrice before going for that. Thank you.
One thing real quick is that the infectious disease burden is much higher in Pakistan, but both the studies from UK, David Eisenberg's group, and our group has shown that the infection risk in this combination therapy is actually very low. In our 40 patients that we have treated, the only thing that was increased incidence was viral infections, and there is an increased incidence of HSV. And there's only one patient who has developed PCP pneumonia, but there was no mortality. And the same thing if you look at the David Eisenberg from University College London, he has shown quite clearly that the patient do very well. But I think those are different places. I think the environment is different, it's more sterile. And here the infectious disease burden is higher, so you have to keep that in mind. Very good point. Thank you.
Yeah, just one point to add, cyclophosphamide dosing. So sometimes we have gotten away by reducing the cyclophosphamide dose. I would strongly still recommend to check the APLs and consider anticoagulation. Again, it's anecdotal, but I've seen patients who biopsy showed thrombosis despite them being APL negative, and they did well on combination of anticoagulation, vasodilation, and immunosuppression. And keeping in mind the dosing that you are using, we hardly ever use now 1 milligram per kilogram dosing of steroids. Yeah, that's kind of a myth for us. We have gone down significantly on steroid dosing as well as cyclophosphamide dosing.
Thank you so much. Thanks a lot.
In the name of Allah, the most beneficent, the most merciful. I am Dr. Arshad, one of the fellow in rheumatology department, and today I'm here to present a case, rather series of events with you of an interesting case. So Mrs. XYZ, 34 years old, she presented to us in our outdoor patient department with history of recurrent pregnancy losses. There were total 7 pregnancy losses from 2010 to 2017. 4 of them were first trimester and 3 of them were second trimester pregnancy losses. So the review of system for connective tissue disease, including lupus and infections, was negative when she presented to us. And as far as her comorbid conditions were concerned, those were also not present. And her family, past, and personal history were not significant at all. And she was vitally stable at presentation, and clinically her physical and systemic examination was completely normal, other than the presence of levator reticularis on her skin. So moving forward, we investigated her, and her baseline labs were normal, which includes CBC, LFTs, RFTs, and her urine complete examination. It was completely bland, nothing was present on it. But we investigated her further by confirming her ANA status and her ENA profile. So multiple things come out to be positive. The ANA was positive at the titers of 1/320. Anti-DS DNA came out to be positive when we did it by criteria method. Anti-Rho was positive, and she was double APLS positive. And the antibodies that were present were lupus anticoagulant and anticardiolipin IgG. So this was the thing, the new thing that she got to know about it, and she was labeled as APLS secondary to lupus. So while we were, at that time when she came to her, we ruled out other things which are, we can say, differential diagnosis of her. So we ruled out other prothrombotic states, pregnancy-induced hypertension, torch infections, and hypothyroidism. So after ruling these things out, we labeled her as APLS secondary to lupus. So this slide is kind of series of events, what exactly happened to her afterwards. So she was allowed to conceive after her lupus was stable. So this time, we added further medications, which included Clexane, Delta-Cortel, Loprin, and HCQ. So we tried all those 4 medications in her, and she was doing good, but unfortunately, at 32 weeks, she lost her baby due to development of severe PIH, and she was she once again lost her baby as per obstetrician advice because she was unable to continue. So my question was here to all my distinguished guests here and my seniors, that what we could have done better to save her baby at this time. So thank you, and I will hand over the stage to my seniors.
Thank you, Arshad. Abid?
Thank you, Dr. Arshad. Now I'll open the stage for discussion. If anyone wants to ask a question or any comments from the panelists.
Can we take help in her case with IV, IG immunoglobulins if she, right?
Here I would like to make a comment, being an obstetrician and gynecologist. We receive these type of patients very often. And our first differential diagnosis, it's a huge learning for me today. And I would say it's amazing because as an obstetrician, we most of the time think about chromosomal abnormalities. Probably there are some translocations or deletions, but this is an important differential diagnosis. And sitting here, I'm realizing that SLE, as we discussed day before yesterday, we are having 24,000 deliveries per year in Gangaram Hospital. And we do get those kind of patients where there are recurrent pregnancy losses, first trimester as well as second trimester. But the only limitation, which I think you will all sitting there will agree with me, that in our public hospitals, we don't have facilities for investigations. And costs does matter. All those investigations which this patient, she got like anti-cardiolipin antibodies, DNA and all those things, they are not available in our hospitals. We only limit ourselves to the baseline investigations. Anti-nuclear, anti-cardiolipin or lupus antibodies, these are done by the private labs. But yes, Dr. Bilal, thank you for enlightening me, and now this is an option, especially where there are recurrent pregnancy losses. One should always keep this in the differential diagnosis. And secondly, with the PIH, eclampsia is still a reality. Our patients, they die with eclampsia. And we wonder that why few patients, they respond differently from others. Probably they are having some autoimmune basis for that, and they develop uncontrolled hypertension at as early as 30 weeks, 32 weeks, and we are unable to control even with higher doses of antihypertensives. So thank you so much.
Thank you, thank you. So the bottom line is that any patient with recurrent abortions should be investigated for autoimmune disease, SLE and APLS. Dr. Nigat, you had to give some comment.
So basically her lupus was controlled throughout, and you know, it was in the end the hypertension which could not be controlled with so many medications that she lost her baby. So we know as rheumatologists, could we have done something different? Laura, Aisha, Hasni, Beena, any, Sadia?
Excuse me?
Anything?
Patient is Rho positive. We should look for heart blocks also in this patient.
She was getting fetal echoes.
Okay.
Oh, yes. Okay. She was doing fine there. That's our routine.
I just wonder about the steroid. I know 5 milligram is not too much of a steroid, but if you have someone with resistant hypertension to be treated, and disease seems to be controlled, whether withdrawing the prednisolone will help. I know it's 5 milligram only, but you're scraping the bottom of the barrel, right? We really can't control. I mean, losing a pregnancy to just hypertension is really a tragedy. So it's not like it's lupus, it's not heart block, baby didn't die in utero, and she lost her baby. So possibly withdrawing steroids. I don't know what antihypertensives were used. We work with our obstetricians, and we sometimes give combination antihypertensives, in fact intravenous as well. So I don't know whether that was tried. 32 weeks is very near term. I don't know what's the neonatal support. Could early delivery with neonatal support, I understand the resource constraints, but yes. If you ask me about IVIG, I personally would not recommend in this situation, because the issue was not really rip-roaring disease or anything, it's high blood pressure. And you know IVIG is a fluid load. So in that situation, and it's a prothrombotic as well. So she's APL positive, she's already hypertensive. I would hesitate to give. There's hardly any evidence and no study or literature come to my mind to answer this question. But going by first principles, I would hesitate to give IVIG. I would try and withdraw her steroids if possible, use combination antihypertensives, try and see whether I can pull a little bit longer, deliver the baby prematurely, and get neonatologists to support.
Thank you.
Her hypertension as soon as she
Thank you.
delivered was fine. And she got all combinations of antihypertensive therapy.
Any other comments from, there's a question from Professor Wajahat.
These babies, they develop with hypertension, they develop intrauterine growth retardation as well. So there are two comorbidities, IUGR plus prematurity. So survival probably is compromised because of these two issues.
Just a thought process. Would a biopsy of the placenta have helped us through a better understanding of was it more thrombotic or was it more ischemic? Would that have helped in any way?
Yes. She was on full dose of...
No, but whether the placenta showed excessive thrombosis or anything of else.
So anticoagulation was therapeutic. So even if we had done it, we know we were treating her for that. So that's a good thought when we don't know what's
Just
happening.
want to know whether it was really thrombotic, we were predisposed because of antiphospholipid, or was it because of some other reason? May have helped.
She is traumatized. So should she get pregnant again? What do the experts say?
I should like to...
I wouldn't say no. Pregnancy for a woman is probably one of the most important life events, especially if they have no children of their own. I do agree that placental histology will be very helpful. I don't know her weight. Sometimes I go up on the Clexane dosing to 1 milligram per kilogram, not limiting myself to 60 milligrams. I have given up to 80 milligrams BD. I've even tried increasing aspirin. There is some study showing that it doesn't matter whether you give aspirin 7,500 or higher doses, but again, you are scrapping the real bottom of the barrel. So increasing aspirin to 100 or 150, giving weight-based low molecular weight heparin, so up to her weight. I would give her hydroxychloroquine 400 daily as you were giving. I probably wouldn't give her steroids. And yeah, we have missed the boat, so there's no histology, but prophylactic IVIG for the next pregnancy. Not this one because it was hypertension. Again, this is open label data because randomized controlled trials were not positive. There were two. But trials are trials, and when you're faced with real life situations in a desperate woman, I would give IVIG. I've done that for selected cases with an open discussion with patient and documentation, at least in our setting where documentation and being clear is very important. 3 to 4 weekly IVIG for at least first few months. That would be my suggestion, but affordability and understanding, especially that this is really a trial and that there is no robust evidence of its efficacy. Data is really mixed. So open label observational studies have shown benefit of IVIG, randomized controlled trials did not. But in a real life setting, that's what I would do for the next pregnancy. You have thrown everything. If you look at EULAR guidelines or ACR guidelines, which were published in 2020, they diverge a bit here, but basically these are the therapeutics. Aspirin, low molecular weight heparin, hydroxychloroquine, plus minus prednisolone. IVIG opinion is a split. EULAR says give it a try. ACI is conditionally recommending against it. But in this setting, personally, I would give it a try.
Thank you. Thank you. I think this concludes our panel discussion. I would like to thank all the panelists for such an active discussion. And you can go back to your seats. Now we'll have the third talk of our session. And I'll request the stage committee.